call it secondary active? Anyone? And if you can give me examples also. Yes, Christian?
I was gonna say secondary active transport like takes advantage of a primary active transporter, and like an example that I was thinking of is so you have the primary active transport for sodium, potassium, ATPase, and glucose takes advantage of that by using the sodium to go down the gradient and enter the cell.
Very nice, Christian. Thank you so much. I'm just going to explain it one more time. Before I go ahead, Christian, can you mention why do we call it secondary active?
Because it itself is not using the ATP directly to, I guess, get into the cell, but it's taking advantage of like a gradient that was created by a primary active transporter.
Very nice. Thank you. So it directly is not using any energy, as you can see here. This is your SGLT transporter sitting in the membrane, which is riding where glucose is riding just with sodium through this transporter, right? But this sodium gradient, which was prepared by primary active transport, is basically helping glucose to go into the cell. Yes, Diego?
Um, can you say that reverberation? I'll ask the question in the chat.
Yeah, quickly, because I think somebody else in your room is also signed up close to you, or you're signed up from two places. Okay. So Diego is asking a question. Where is the question, Diego? You want to ask, or should I unmute you? Or you're typing? Okay. We're waiting. Glucose sodium pump. No, we don't call it facilitated secondary transport. No. Facilitated is just a passive diffusion, not using any form of energy, where your secondary active transport is using a form of energy that was provided by the primary active. Okay. Facilitated diffusion is a passive way of diffusion where just, um, protein is just taking something and taking it through the membrane, right? Is it clear? Okay. All right. Any other questions so far? So be ready with the examples for primary. How does it happen? Secondary. What's the mechanism? Examples for symport and antiport. You should be ready for the exam. Okay, I'm just looking at the chat. It is sodium is going down constantly, so glucose takes advantage. Yes, absolutely. It is so if you see here, look at the primary active transport here. Here, the ATP is providing the energy, right? So it's pushing sodium from the cell against the gradient, right? So this is against the gradient. That's why this uphill transport is using energy here. Same thing with the 2 potassium. At the same time, when you are looking at this, also keep in mind for our week 2 material that this is an electrogenic transport. So you are pushing 3 sodium out while you are getting 2 potassium in, right? So 1 extra positive charge is being pushed out here. I will talk more about it tomorrow, and you will see how this thing helps the resting membrane potential tomorrow when we talk about the action potentials, right? So this is your primary active, which is building the potassium gradient inside, sorry, sodium gradient outside and potassium gradient inside, right? So here you have enough sodium high concentration, inside sodium concentration is low. So there is always a tendency of sodium to go in, right? So riding on this SDLT transporter, sodium, when it's trying to come in, it's also importing glucose with it at this point. Or it could be doing antipode, where the rotational or the conformational changes on the transporter is such that when sodium is coming in, at the same time, the conformational change will push calcium outside, or it can push hydrogen ion outside. Yes, Jasmine has a question, Jasmine? Jasmine? Oh, you are on mute.
Sorry about that. So regarding the primary active transfer sodium potassium ATP, should we be very familiar with the E2P phase and the E1P phase?
No, you
and
don't
some of
have
the
to. No, it's okay. As long as you know what the process is, we're good. Yeah. Okay.
and so we don't have to worry about like cardiac glycosides and like inhibitors.
You do have to
of,
worry about that. Yes, that's my next slide. I'm gonna go there now. Diego, you have a question. Is it a question from this supplemental or is it from week 2 material?
No, it's from week 2, so
Week 2, right? Okay, so we'll talk about it tomorrow. Let me finish week 1 first, or you can come to my office. We can talk about. But what you are saying is correct. So basically, urea is so permeable, it crosses the membrane. Okay. All right, so let me get to the next slide because I want to finish the water shifts, different compartments, very important, and some students may still not be there, so I want them to be ready for the exam. This chart is going to be very important for the exam. So as I told you so many times, you need to know by now what is your sodium concentration outside in the ECF, where exactly your sodium is staying, where exactly your potassium is staying. It is inside. So that's one of the major cations, ICF, right? Sodium is major cation outside, so they have their own specific roles to play. Can anyone tell me why do we have this concentration differences across the membrane and what roles these concentrations play or the gradients play? We discussed about it in the class, so if you can just rewind.
Would it be the plasma proteins are responsible for the differences in the ion concentrations?
Yeah, yeah, partly that's true, but the concentration differences, why they are maintained and what roles do they play? That is my question. Gibbs-Donnan is correct, Andrew. I'm asking. Yes, Sadaf, you can go.
It is to keep the equilibrium potential.
To keep the equilibrium potential. Very good. Who else? I saw another hand raised. Yes, Jonathan, please go ahead.
It's to force the ions to go inside and outside the cell to follow the forces that are being forced by the differences in the concentrations.
Yeah, that's true, but why do we have these concentration differences? What roles do they play? Yes, Sadaf? Oh, okay, Jasmine. J is correct. Yes, you have to have electroneutrality around the membrane, but for what? What are the roles being played here? Jasmine, you are on mute.
to generate the concentration gradients helps the active transporters take advantage of the
Very nice. To keep the concentration gradient going with the active transport, but all your secondary active transport is based on that, right? So glucose coming in, amino acids coming in, or calcium going out, hydrogen going out, all those functions are based on the secondary active transport. So you got to maintain the concentration gradients in and out. What else? Osmolarity, yeah, correct. Resting membrane potential. I don't know who iPhone is. Who's this? I see iPhone logged in and gave me the correct answer. I just want to know who this is. Jaylene, all right. Okay, Jaylene, thank you so much. So, I mean, if we didn't have these concentration gradients maintained there, and you will see tomorrow how big difference that will make. You don't have any action potentials. Your muscles can't contract if you don't have action potentials on neuronal cells, right? And so forth. So we'll learn a little bit more, but all your transport is based on these concentration differences across the membranes. Your resting membrane potential on the membrane is based on this. Your action potentials, they are based on this. All your muscle physiology is based on this. So please keep all those things in mind. And the reason I brought this table up, you got to be ready with this table. This has to be imprinted. Very important for exam. Okay, now the question someone was asking, I forgot now, probably Emma and Jasmine. Okay, so what if you block primary active transport for the sodium potassium pump here? What do you think, what kind of problems this will bring? Or someone who's on cardiac glycosides, what do you think is happening to them? Andrea, yes?
So we just mentioned how primary active transport impacts all of secondary active transport.
Yes.
So when you inhibit the conformation change for the sodium potassium ATPase pump, you also in turn inhibit the calcium sodium antiport transporter, which then keeps calcium inside the cell for longer and results in a stronger contraction.
Very nice. So I'm just going to explain it one by one. Thank you so much, Andrea, for answering this question. Yes, Diego is right too. So here, if you are blocking this pump, you are not building the sodium gradient, right? So sodium was basically being pushed out by this pump. If you don't have enough sodium concentration out here, your secondary active transport will be impacted, right? So your functions which were done by the secondary active transport, such as bringing glucose in or amino acids in or hydrogen ions being pushed out or calcium being pushed out, all these things will be heavily impacted. You see my point? So if you're not bringing glucose in, how are you going to absorb glucose into the blood, right? This was the lumen of a GI cell. So all glucose is sitting here. You don't have enough sodium gradient here to bring glucose in. You cannot extrude any glucose into the blood here. So your absorption is impacted, right? Same thing with the calcium. When you were anti-porting calcium from a muscle cell riding on a sodium gradient, now this is also impacted, right? So this is not happening. So what will happen? The cell will trap more calcium inside. So what will happen? If cell is trapping more calcium inside, what will happen to the cell? Yes, Christian?
The muscles will contract more.
Very nice. So there will be a stronger contraction. So initially, as I told you, these cardiac glycosides, they were digitalis, that was given basically to heart failure patients or to get them out of the arrhythmias. So you give them, so you have a nice magnitude contraction by trapping more calcium in. But you can see, like if you're blocking pump, it's going to block pump everywhere around, right? So other activities will be impacted. So this is not any more drug of choice. But it's a good example to learn about the primary active transport and secondary. So I always bring it in. Okay. Yes, digitalis and open. Yes. Okay, you are correct, Andrea. All right. So the table back again, but you got to be ready. All right. So we're gonna go back to the shifts as Jasmine was asking earlier. We're gonna talk about these more. So let's match them again. So you guys are ready with the stuff. So what would you match A with? Which option? Diarrhea is correct. Very nice. Or something other clinical scenario that comes to your mind besides diarrhea? Hemorrhage. Beautiful. Beautiful. All right. So D is correct. There is an isotonic loss. So if you are not seeing any change in the osmolarity here, that means you don't have to worry about any shifts in the compartments. Okay, this is simple, as easy as it could be. Only volume is lost, and that too from the ECF, because your plasma is going to get impacted first. So D is correct, isotonic and hypovolemic. We don't have any change in the osmolarity. We only have the volume change. So volume loss is happening here. What would you give this patient to recover from this loss? Let's say you have a patient with hemorrhage. Beautiful. You just want to fill them up with the volume by giving them 0.9% saline. Beautiful isotonic saline. Very nice. All right, let's go to B. So what do you think is happening here and how do you match them? What's happening with this patient? And you got to give me the clinical scenario as well. So dehydration, beautiful. So patient lost what? You are matching it with A, right? Hypertonic, hypovolemic, because volume is both down in the ICF and ECF compartment, and they have higher osmolarity. So if you draw it with the dotted line, you will see that, right? Now, patient lost hypotonic fluid. Yes, the Dhruv, you are correct. So what would you give this patient now to get them back? To get them back. Jay, that's not correct. So patient has lost hypotonic fluid, right? Yeah, you want to give them hypotonic. See, they are already hyper here, right? So you cannot give this patient hypertonic saline, right? You have to give them more water and little bit solute in it. So it has to be hypotonic. It's as easy as you already told me that they have lost hypotonic fluid, right? So you have to compensate them with a hypotonic fluid, right? So if you put yourself in a STEM with a clinical scenario, and that's what you are looking at, the questions that you will be looking at, okay? The same way, what I'm explaining to you. All right, so what are you matching C with now? C is hypotonia and ECF hypovolemia. Very nice, very nice. Perfect. So what is this situation? What happened to the patient? Beautiful. The patient is having adrenal insufficiency. Can anyone explain what was happening here? Low aldosterone. Very nice, Andrew. So who will explain? Beautiful quiz. Sodium is not getting reabsorbed at the kidney tubules. That's what your aldosterone does for you, right? So it picks up sodium from your distal convoluted tubule, almost 25% there. So this patient is not able to absorb that, right? And they are also losing water. So as I told you, the golden rule is water is gonna follow sodium. So if patient is losing sodium, they're gonna, that's what diuretic medications are based on. So keep those in mind. We'll talk more about those as we get to renal, but I don't want to give you like heavy information yet. But let's keep it to, so if patient has lost sodium, right, they are hypo here. Always draw it out on your scrap paper so you get to the final. So I'm just giving you a final version of the figure, right? So you want to draw that out as I did it on the whiteboard yesterday. So your ECF is impacted first, and then your ICF it was still hypertonic. So there is a fluid shift from ECF to ICF. And you see that the ICF compartment is hypervolemic, and then they are both at the equal steady state as far as the osmolarity is concerned. Okay, so keep that in mind. You want to give this patient sodium back, right? You want to give them hypertonic saline to compensate for that. Correct? Everyone is clear about this? Yes? Okay, the next one, D. We only have one option left. Yes, Thomas. Okay, hypotonic, yes, and hypervolemic. So clinical situations, there could be two. SIADH, what does that stand for? You have inappropriate amounts of ADH here, right? So what is this patient doing then? If you have more antidiuretic, as I explained to you yesterday, antidiuresis, right? No more urine makeup, right? So it's retaining water, and that is basically bringing the osmolarity down in the patient because it's retaining water inside. Both ICF and ECF compartment, they are hypervolemic, and reason that they are gaining water, the solute is staying the same, so that is bringing the osmolarity down in the patient. Is everyone clear about that? Yes. So how would you treat such kind of patient?
Professor?
Say it again, Karan.
Sorry, Professor, can you go over that one again? I missed what you said earlier.
Yeah, sure.
Thank you.
So thank you for bringing it up. So in case someone didn't get it yesterday, so this is a clinical scenario where the patient is having inappropriate amounts of ADH hormone. I mean, they are secreting it more, right? Where is ADH coming from? Where is it synthesized? Does anyone know? No, ADH is not coming from adrenal medulla. No. Not from, yeah, yes, Pursum, you are right. Basically, hypothalamus makes ADH, and it is stored in posterior pituitary, and that's where it is being released from, right? So patient has inappropriate, and as I said, if you go by the name of ADH, this is called antidiuretic hormone. So it doesn't let you pee if it's there in the system, right? It's conserving water, it's reabsorbing water. It's working on the ADH receptors to suck water back in or reabsorb the water from the kidney tubules, right? So if someone who's having inappropriate amounts of ADH, obviously they're going to retain more water inside the body, which is basically bringing the plasma osmolarity down first. As I said, your first compartment that's going to get impacted is going to be your ECF. So if that's going down, obviously there is a water shift that's going to happen from ECF side to ICF. and your cells are also absorbing water now, right? And I explained you yesterday, you will always see more water shift towards the cells because your ICF is 2/3 as opposed to ECF, which is 1/3. Does that make sense, Karan?
Yep, got it. Thank you.
All right, so you want to treat such a patient by giving an antagonist to those receptors so your ADH can't work as much, right? To get the urine formation back. Any other thing that comes to your mind when we see such a figure? Simple scenario. Yes, drinking too much water, plain water, where you're not adding any minerals or any ions or anything after vigorous exercise. You're just drinking 2 liters of plain water. You're basically bringing or diluting the osmolarity there. Yes? Yes, overhydration. Good term. Yes, Jasmine, you have a question here?
Yeah, so just to clarify, when the regarding letter D, that diagram, when the osmolarity in the extracellular fluid goes down, the water is going to flow from the ECF to the ICF. Is that correct?
Yeah. Yes.
And then that's when it will.
That's automatic, right? This is osmosis. So it's gonna go
Okay.
to low solute to high solute because of the pressures that are being built up. So I will explain it a little bit more tomorrow, week 2. We're gonna talk about osmolarity a little bit more. But in the meantime, I won't wait and go over the supplemental questions for week 2 so you can prepare yourself before you come to the class tomorrow. There are a lot of questions to practice for you guys. Okay, it's a very good practice for week 2 supplemental material. I already posted the answers to in case you have any problem. There are speaker notes underneath. I've explained the options nicely underneath, so in case you're having any trouble, but I'll be there in class tomorrow, so we'll discuss it more. So are we good for this? Deborah, we won't give this patient hypertonic at this point. If it's just like a gymming and overhydration, then it will calm down on its own. But if it's SIADH, then obviously you want to give them an antagonist to work against the receptors. So ADH can't work, so patient can pass urine out, right? Doesn't reabsorb as much. Okay, all right. So one more time, in case you didn't get it, the golden rule, first compartment that you have to look for is your ECF compartment. That's your plasma. That's going to get impacted whether you are eating more salt or you are losing water by any means. If there is any osmolarity change by adding more water or losing more water or adding more salt, you are basically impacting the osmolarity. If you're adding more sodium, you're going to take this osmolarity up in ECF first, and then starts the changes from one compartment to the other. So water has to shift so it can bring both the compartments at a steady state. As I told you, they have to come at a steady state in and out. So keep that in mind. And that's what is gonna, end up happening. ICF osmolarity should match ECF osmolarity, and that is driving your water shift across the membrane, between the 2 chambers. Okay, is everyone clear about that? Yes. Okay. All right, let's move. Yeah, so this slide is basically explaining you like why this is happening. Yes, Shabab, you have a question?
Hi, I do have a question, Dr. Carr. Hopefully,
Yes.
to resolve the situation in D, where it is hypotonic and hypervolemic, Oh, sorry, yeah, and hypervolemic. Would you also utilize hypertonic saline or saline solution in order to fix that?
So, as I said before, if it's a situation where someone went to the gym and just overhydrated themselves, it will all clear off by your kidneys soon. Okay. And then you can always, that is what is recommended after vigorous exercise. You may want to have some minerals in there or something, which is compensating for the loss of solute too, minor loss of solute that has happened if you are vigorously exercising or adding more water to your body. So in a normal situation, you don't have to do anything. But if it was SIADH issue, which is the major issue, so hypothalamus has a tumor, which is basically making more ADH for the patient, then they have to use antagonist for that. So where ADH can't bind to the receptors and it doesn't reabsorb as much water. You see my point?
I understand now. Thank you.
Yeah. All right. I don't think we will be asking you for the treatments for this exam. It's out of scope for this exam. But the basic questions you should be ready, where we talked about diarrhea, we talked about hemorrhage, we talked about hypotonic saline, those kind of situations. All right. Okay. A few more questions before we move on. So you are ready for the exam. So if the patient is having diarrhea, what is the situation here? What would you match it for? Very nice, very nice, very happy. What other clinical situation matches here? Burning, beautiful, burning, hemorrhage, very nice. Okay, very happy with the outcome. So I think we are kind of ready. I won't go over all this. I think you guys are pretty good about it. So let's get going. I'm just gonna move to the next slide. So I just put it for your reference down here. So in case when you are preparing, you have these lined up. You don't have to look elsewhere. Dhruv has a question, Dhruv?
Could emesis also be an example for this or no?
Which one?
Emesis or throwing up?
Yes. As long as it's not like a heavy, heavy vomiting. Heavy vomiting may have some bicarb and other stuff in it. So at that point, it's a different situation, but regular, some vomiting can lead to, this isotonic loss. Okay.
Got it. Thank you.
All right, great. We have, yes, Parambir, there will be recording that will be posted tonight to the Canvas. But good questions and good discussion. All right, so heavy stuff. Let's do it together. So let's go by A first. So if someone is ingesting salt tablets or there is infusion of hypertonic saline, what do you think you'll match it for? 1, 2, 3, 4, 5, 6. Hypertonic saline. And you got to draw it out. I told you if it comes in exam, you got to draw it out. What I'm giving you is the final figure, right? There are changes that started happening in ACF first, and then other things will take place. Okay, anyone? No answer? Okay, some of you are writing 2, and I see 3 as well. Okay, Swan, do you want to explain it to us? Aiden, this
Yeah,
is
sure.
not 3, 2 is the right answer. So yes, go ahead, Aiden.
So when you are
Osman.
gaining hypertonic, which means you're gaining more solute. So when you look at osmolarity, it'll go up. And when the osmolarity go up, if you look at ECF, in order to dilute it, we need like more water.
Yes.
So ECF will pull water from ICF, and that's how we got number 2.
Very nice, Usman. Thank you. So I'm going to explain it one more time in case you didn't get it. So if this patient was ingesting salt tablets, let's assume that they had higher osmolarity in ECF compartment first, right? So if your ECF was hypertonic, what is the next stage? Your cells will be shrinking to send some water this side. Yes? Am I correct? Everyone got it? Okay, perfect. So cells are shrinking, they are losing water, and there is a water shift which is happening because of the higher osmolarity towards the ECF side. And ICF and ECF, they want to come to a steady state to the equal osmolarity. So osmolarity is now down a little bit here, right? Earlier it should be up here somewhere. So that is a transitioning figure in between, which books won't show you or you won't find elsewhere, but I tell you all the time, when you get such a question in exam, just try it out. Okay? That will really help you. Is everyone clear on this? Are we clear on this question? Yes? All right, so my next question to you is, I'm going to go straight to G. G is infusion of isotonic saline, which has dextran in it. So what do you think is happening? Which one is correct? Dhruv is saying 1, most of you saying 2, and 1. 1 and 2, 1 and 2. Okay. Can anyone tell me what's the difference between 1 and 2? Who will explain? You guys are divided. So first of all, we need to resolve 1. Very nice, Dhruv. 1 doesn't have any increase in the osmolarity. It's just increasing the isotonic fluid, right? So that can't be a situation here. We are also adding dextran to the isotonic saline. So what is happening here? What's going on? Can anyone explain me? I did explain yesterday. Yes, Ariana is saying if you add dextran, which is a high molecular weight carb, it just sticks in the ECF. We call it plasma expander. So in case you see a question in exam for dextran, just remember one name, plasma expander. When we say plasma expander, that means it's going to fill up your ECF volume. It can't cross. It cannot. It just cannot cross this membrane, right? So if it can't cross, it's going to stay here and bring the osmolarity up, right? If osmolarity is up here, what's going to happen? Your ICF volume will move towards ECF. So it's going to be 2 again. Is that clear? Is everyone clear about that? 1 is just building up more isotonic fluid, right? It doesn't have any osmolarity up here. So this will be matching to which one? First is matching to, first figure is matching to infusion of isotonic saline. Beautiful. D is the right answer. Very nice. Very nice. Okay, perfect. All right, so next one, drinking 1 liter of pure water. What do you think it will match to? Very nice. Very nice. I think I prepared you well enough. I'm happy with the outcome now. So yes, 4 is correct. You are bringing the osmolarity down by adding pure water, right? and the volume is being built up both sides, and osmolarity is down here. Right, great. Volume and salt depletion. C. Volume and salt depletion. Yes, that's correct. We lost volume, we lost salt, right? So what's going to happen? Your ECF will get impacted first, right? So once your osmolarity is down, your changes will start to happen. So water shift is going to take place from ECF to ICF because your cells had normal osmolarity by this point, right? Now the body wants to get to the same state, right? So your shift will be happening towards the cell side because your cells are automatically retaining 2/3. Yes. Okay, I think we're doing pretty good. Loss of hypotonic fluid. E. Great. Great. 3 is the right answer. Yes. Perfect. We did it just recently. Okay. Okay, we lost one point here. Infusion of isotonic saline. D is matching. D is matching 1. Very nice. So you're just adding isotonic saline. It's not going to bring any osmolarity changes because you have 0.9% saline that you are giving the patient, right? We did F, loss of isotonic fluid. Which one is that? Isotonic, yes, very nice. No osmolarity changes because it's isotonic. Just look for the word iso. So if it's iso, it's just going to impact the ECF compartment. It's not going to impact your osmolarity at all. Okay, so are we all good on this so far? Any questions on this part? Are we doing good on this? So I did put for you guys basically, let me just on these annotations to stay here. Okay. I have put the answers for you here up on this slide. So in case you are preparing this, slide is already up, I guess, in week 1. So please go through these questions, try them yourself and try them transitionary, one by one, draw them out. Okay. Yeah, which of the patients would require hypotonic saline out of these? Beautiful. Beautiful. And what is this clinical scenario, the C? Clinical scenario C is adrenal insufficiency. Very nice. And what is this? D? D is SIADH, or someone who drank plain water, right? They drank too much of plain water. All right, great. I think we are doing pretty good on these. I drew these for you here as well. So, you know, you'll have speaker notes underneath too, in case you need any help. And I guess, so this is the question we did yesterday, just matching which one is this. And I guess everyone answered yesterday, but in case, yes, Chris, thank you. That's the right term here. Water intoxication. Beautiful. A will be matching hypertonic and hypovolemic. So in case anyone thinks that they still didn't get these problems, please come and see me before we move to week 2 is very dense. I'll be discussing that tomorrow. I'll do, I'm thinking of doing a Zoom tomorrow together at 12 p.m. So both MS and DO can be catered at the same time. in case that's possible. Just let me know what your feelings are about that. Do you think that's doable? That way I can handle all the questions. 12 to 1. Yeah, that's our supplemental for week 2, and I'm going to use it for reviewing the exam too. Yeah, the optional supplemental, I'll be using it as supplemental and reviewing too for Friday. But since it's going to have like heavy content, that's why I wanted to. So Dhruv is asking, some of the DO students, they start OMM lab at 1 p.m. I'm not sure about, I think 12:45 does 12, but I'm finishing class with masters at I think I have class with masters 11 to 12, isn't it? Yeah, masters are busy 11 to. Do we have 2 Dhruv Patels? Oh, okay. That's interesting. We have 2 Vidhis also, 2 Vidhi Patels, one in MS, one in DO. That's a coincidence. Yeah. Okay. All right, great. So I think 12 I'll start. You can it's gonna be on Zoom, so you can have your lunch on the side or whatever you want to do on the side and take it easy. And I'm here in the afternoon. If you have any question, you can always stop by. Okay. All right, so with this, we finish.